Hi, today we're going to talk about the integumentary system. We've discussed in the past how tissues are organized to form organs and organs are organized to form systems. The organs of the integument system include the skin and some accessory structures, which include the hair, nails, and the epithelial glands. Skin is considered the largest organ of the body, and it could weigh between 10 and 11 pounds. A dermatologist is a medical specialist who is whose specialty is in the treatment and diagnosis of the integumentary system. So let's talk about some general functions of the integumentary system, which include protection. It separates the internal versus the external environment of the skin. The excretion of wastes, which includes salts and water and some organic waste through sweat. There's some absorption in the skin. Maintenance of normal body temperature through thermal regulation. We synthesize vitamin D, which is important for calcium metabolism. We store nutrients, for example, in the adipose cells of the dermis. It's a very sensitive structure, so we can feel touch, pressure, pain, and temperature. And the integumentary system acts as a blood reservoir. So let's discuss the structures of the skin. There's two major layers of the skin. The outer layer is called the epidermis, and the inner layer is called the dermis. The epidermis histologically is made up of keratinized stratified squamous epithelium. Remember, we were taught that stratified means more than two cells. Squamous is that top cell is flat, and it's that outer epithelial layer. The difference between the stratified squamous epithelium on the external skin or the stratified squamous epithelium, for example, in the inside of our mouth, is this protein keratin. So the skin is keratinized, where inside the mouth does not have the protein keratin. Below this, we have the dermis. Dermis histologically is made up of areolar, loose connective tissue, and dense, irregular connective tissue. Remember, we learned in the past that that tissue is is like a filler, and the dense irregular connective tissue has elastic and tensile strength in many different directions. Below this is the subcutaneous layer or hypodermis. So when we think of the term skin, it includes the epidermis and dermis. This subcutaneous layer or hypodermis is not considered part of the skin. All of these regions are part of the integument system. So this hypodermis is not part of the skin, and it's mainly made up of adipose tissue and areolar loose connective tissue. So we talk about the epidermis, which is keratinized stratified squamous epithelium. It has four types of cells, which we'll go into each of these in detail. Keratinocytes, which most of the cells in the epidermis is keratinocytes. It has melanocytes, which are responsible for our skin color. There's intraepidermal macrophages. So just like the name says, also called Langerhans cells, there are immune cells, and there's tactile epithelial, which makes the skin very sensitive. So most of the cells are keratinocytes. So let's discuss some more details about each of this. So again, the integumentary system includes the epidermis, the dermis, and the hypodermis, or the subcutaneous layer. Epidermis and dermis is what we consider the skin, the subcu is not. So when we think of the epidermis, it's also the epithelial layer, or that outer layer, Remember, it's called stratified, keratinized, stratified squamous epithelium. So we know already that this is non-vascular. So think of a paper cut. If you have a little paper cut in this epidermis, will it bleed? No, it should not. Will it hurt? Yes, it hurts because there's a lot of nerve innervation in that area. So let's go into more details about the four major cells of the um, epidermis, or the keratinized stratified squamous epithelium. So keratinocytes produce the protein keratin. And this is a very protective protein. It actually releases a water repellent sealant over the skin. So it prevents water loss or absorption of foreign materials. So 90% of our epidermal cells are keratinocytes, and most of these are located in the stratum corneum. We'll discuss in a little while that the epidermis is made up of layers, and they're called stratum. So the corneum is the top layer, and that's where most of the keratinocytes are located. The second type of cell is called the melanocyte. So melanocytes produce melanin. The natural melanin in our bodies contributes to the different skin colors that exists. But when we're exposed to UV radiation or sunlight, these melanocytes produce more melanin, which gives us that tan color we get when we're out in the sun. But if we're out in the sun without sunscreen, what gets damaged are these intraepidermal macrophages, or Langerhans cells. So the melanin produced by the melanocytes actually protects the DNA in these intraepidermal macrophages. And if we do not use sunscreen or are out in the sun too much, often when the DNA in these macrophages gets damaged, we're more susceptible to skin cancer. And these intraepidermal macrophages are located in the stratum spinosum. The fourth type of cell are Merkel cells, and they're called tactile epithelium. They're located in the deepest layers of the epidermis, and they have what we consider Merkel discs, and or sensory neurons, which are very, very sensitive to touch. And they're located in the stratum bacilli, and we'll look at this in a minute. So again, to review, keratinocytes produce keratin, which is a very protective sealant over our skin. Melanocytes produce melanin, which gives us the tanning color, also protects the intraepidermal macrophages, or Langerhans cells, protects the DNA. So the immune system of our skin is very active. And then we have these tactile or Merkel cells, which are connected to the sensory neurons, which makes the epidermis very sensitive to touch. So there's 5 major layers of our skin. The first one is the stratum bacilli, which is the deepest. So this is where we have continuous cell division, and we've got the keratinocytes are in this layer. We also have melanocytes, and we have the tactile epithelium cells in this region. Stratum bacilli is also called stratum germativum because it's continuously forming new cells. As we move up the next layer, that's called stratum spinosum. Remember, we talked about in the past that the Langerhans cells, or these intraepidermal macrophages, are located in this layer. This is the next 8 to 10 layers. Above that is the stratum granulosum. So at this layer, by the time we get to the granulosum, remember we talked about how this epidermis is avascular. So through the dermis, which is very vascular, the nutrition through the blood supply in the dermis is through diffusion coming into the stratum bacilli. So it's feeding into these stem cells, producing cells. So the keratinocytes are producing cells, the melanocytes, and the tactile epithelium are located in this area. So when we get to the spinosum, the cells are still viable and alive, but by the time the cells get to the stratum granulosum, they begin to die under a process called apoptosis. Um, when these cells begin to die, especially the keratinocytes, they secrete a lipid-rich secretion which makes skin very water resistant. So, because of this transition of metabolically active cells and dead cells, these cells begin to look granular. And that's why we call them granulosome, because the organelles within the cells begin to die and degenerate. Then we go to stratum lucidum. So stratum lucidum is not in all areas. We need to know the difference between thin skin and thick skin. So thin versus thick. So thick skin, let me just write this out. Thick skin is only located in two regions. That is the bottom of our palms and the bottom of our feet, which the skin has to be thicker, okay? Mainly because there's a lot more like pressure, more abrasion in the bottoms of our feet and the palms of our hands. So that area is thicker. So only where we have thick skin, we have a stratum lucidum. And then the top layer is the stratum corneum. Okay, this is the thickest layer. It's got about 25 to 30 rows. And by the time the cells get here, they're flat and dead cells. So most of the keratin is found in this layer because it's very thick. So what happens is the cells here called coniocytes or squamous thin flat keratin, they begin to shed off. Okay, so that layer begins to the top layer, because they're really dead at that point, shed off, and that's where we see dust in our homes. So the dust, part of that are these dead skin cells that are shedding off approximately every 4 to 6 weeks. So this accumulation of keratin begins to further die off, and these dead cells begin to slough off. When we see a callus, it's where we have additional skin friction, increases the cell production, that causes an abnormal thickening. Dandruff is also excessive amounts of keratinized cells shedding off the scalp. So let's look at these. So remember the top layer, stratum corneum, and these are all those dead cells. It's very thick, you can't tell on this. Next one is the stratum lucidum. We only see that in thick skin, which is like the base of our hands and our feet. Then we have the stratum granulosum, okay, here. And this is where these keratinocytes begin to die off as they go up this layer. Stratum spinosum, this is where we have the intraepidermal macrophages. And the stratum bacilli, we also call this the germativum cell, because there's got the stem cells that are continuously producing more cells. We've got the keratinocytes here, the melanocytes, and also the tactile epithelium, which makes the epidermis very sensitive. And then below this is the dermis. Okay, so we've got to memorize this. So I like this mnemonic. So stratum corneum, top layer. Generally, this is going to be the thickest 25 to 30 layers. Let's remember stratum lucidum, usually flat, dead keratinocytes, only in thick skin, about 3 to 5 rows. get stratum granulosum. Stratum granulosum can range from 3 to 5 rows of flattened keratinocytes. They look granular, and this is where cells are dying off. Stratum spinosum, sun. So the stratum spinosum, again, it's about 8 to 10 rows. They've got keratinocytes, melanocytes in the area, and they have the Langerhans cells. And then stratum bacilli. The stratum bacilli is the deepest layer, has continuous cell division, and it has the keratin cells, the melanocytes, and the tactile epithelium located in this area. So again, we have to memorize that order: stratum corneum, the dead cells, stratum lucidum. So when you see a stratum lucidum, it looks like a clear region, and this, you know, would be in the palms of our hands or the soles of our feet. Granulosum, we've got the granular looking cells, the keratinocytes are beginning to die off. Stratum spinosum, a big one here, are the intraepidermal macrophages. There's keratin cells and also melanocytes. And then we've got the stratum bacilli, which has all that continuous reproduction of cells, which includes the melanocytes, the keratinocytes, and the tactile epithelium. And this would be the dermis below that. Okay, so make sure you know, come, let's get sunburned, mnemonic. So let's talk about each layer in a little more detail. We've got the stratum germinativum, or the bacilli, which would be this bottom layer right here. So if we're looking at histological slide of stratified squamous epithelium, that is that one layer thick region on the bottom. It's the deepest layer of the epidermis. So the stratum bacilli, which would be this layer here, has the keratinocytes. It's the continuous production of these cells, has the melanocytes, which produce melanin, and also has these many tactile epithelium, which makes it very sensitive to touch. You can see how this stratum bacilli is directly connected to the dermis through these capillary loops. It's very vascular, and the epidermis is avascular. The next layer up is the stratum spinosum, and the cells that are produced in that stratum bacilli can move up into the stratum spinosum. It's about 8 to 10 layers. What makes this area unique is it has these Langerhans cells, or these intraepidermal macrophages, in this layer. The stratum granulosum is next, which is this darker color. It's about 3 layers, and they're flattened, and the keratinocytes are beginning to die off. And the organelles within it begin to degenerate, so they look granular. And this whole process secretes a lipid-rich water repellent secretion, which makes the skin more impermeable to water or other materials. So we talked about how the stratum lucidum is only located in the bottom soles of our feet and our palms. It's transparent, only present in thick skin. And then the top layer, which you can see in this image, is the stratum corneum. So it takes about a month to all the cells go from the stratum bacilli all through the layers and then up into the stratum corneum. So the cells remain in the stratum corneum for maybe additional 2 weeks before they slough off. So at this point, the sebaceous oil glands don't really reach this top layer, so they're easily slough off, and that's what becomes the dust. So the newly formed cells in the stratum bacilli are continuously produced, and as they go through the different layers and undergo apoptosis, meaning cell death, it takes about 4 to 6 weeks till they reach that stratum corneum, and then they shed. So this is a review of what we talked about. I would take each of these layers and make sure you know a description of each of these areas. You also need to know the order of the layers. So stratum calm, let's get sunburnt. It's one mnemonic that I would recommend you use. Calm being the most superficial and the bacilli the deepest layers. Okay. So let's move on below this, and this is the dermis. So the dermis is located below the epidermis, and the dermis is very vascular. This is connective tissue. It has collagen and elastic fibers. So the dermis is made up of two layers. We've got the papillary region on top and the reticular region on the bottom. The way I memorize it alphabetically, P comes before R, so it's important you note this. So this papillary region contains the areolar loose connective tissue. The reticular region has the dense irregular connective tissue. So as we talked about connective tissue, it has collagen and elastic fibers, which allows the dermis to stretch out without tearing and recoil after it's been stretched out. So it has tensile strength and elasticity. And the dermis is very, very vascular. There's the two layers, the outer 1/5 called the papillary, which has the areolar loose connective tissue. Remember, that was a very packing material, very vascular. It has elastic fibers. And in this papillary region, we have the dermal papillae, capillary loops, which are the blood supply. And this area has the Meissner's corpuscles of touch, okay, which is more sensory receptors on the dermis. We also have the tactile epithelial just above this. The reticular region is the next region below this. It's a little thicker. This is made up of dense, irregular connective tissue. Also has a lot of collagen and elastic fibers. So this provides extensibility. So it has the ability to stretch and come back to normal, and elasticity, which it's got the extensibility, the ability to stretch without tearing, and elasticity. It will return to its original shape after it's stretched out. So within this area, we have adipose cells. Here we have the hair follicles, nerves. We'll talk about the different glands that exist here. Sebaceous oil glands around the hair follicles, and sudoriferous glands, which are our sweat glands. So here's that top layer, or the epidermis, with all the stratum. Okay, you could see a little bit the outer layer, corneum, lucidum, so we know this is like the soles of our feet or palms of our hands. Next layer, stratum granulosum, stratum spinosum, and then the germatival layer, or the stratum bacilli. So do you see how this here is the dermis? So the two layers of the dermis are the top layer, which is the papillary layer, and then most of the bottom here is called the reticular layer. Do you see these little bumps? They're called the dermal papillae. So what the dermal papillae do, you could see how the connection between the epidermis and the dermis has these little like puzzle-like connectors, which makes that connection very strong. It's not going to peel off that easily. Also, these dermal papillae are very important because it functions as our epidermal ridges, which gives us the footprints. Let's look at what else is here. Within here, we've got these little loops called capillary loops in the papillary layer of the dermis. And this is what's providing the nutrition and circulatory system, providing oxygen, reabsorbing CO2 through these little capillary loops, which are connected and are very close to the stratum bacilli of the epidermis, which gives that bacilli layer that ability for continuous cell production. We also have these Meissner's corpuscles of touch. So you can see here, these are very sensitive to touch reception in that papillary layer of the dermis. So epidermal ridges, they give us those contours within that dermal papillae that I just showed you. And they give us the ability for fingerprints. So a dermatologic study is the study of fingerprints. This is a close-up of our one of the tufts or the fingerprint itself. There's little sweat pores here, and we see these epidermal ridges. And this is what gives us our fingerprints, okay? And there's a function for this. It gives us a grip strength when we lift something, increases the surface area for sensitivity. As you know, touching things with the tips of your fingers, you're very sensitive. And the sweat glands within the tip of the fingers gives us the fingerprint when we touch something. So let's move on to the next layer. It's called the hypodermis. Remember, this is not considered part of the skin, but it is part of the integument system. So again, if we review this again on our model, we have this model in your lab manual. So up here is the epidermis. The next layer here would be the papillary layer of the dermis. Then we've got the reticular layer of the dermis below that, okay? Then we've got that subcutaneous layer. You see this layer where you see the adipose tissue. This is all considered the subcutaneous layer. So in this layer, it's also very vascular. You can see the vessels. What tissue do you think this yellow is? That's adipose tissue. So there's lots of adipose tissue here. And that was that subcutaneous layer where we often give those subcutaneous injections because it's very vascular. There's adipose tissue in that area. There's also other corpuscles of touch, and these are these here. These are called lamellated corpuscles of touch. So they're very sensitive to pressure sensitivity. In order to feel these, you have to go through the epidermis and the dermis before these become activated. Let's move on a little bit. So let's move on to what gives us skin color. We've talked about that, how variations in skin color correlate with the amount of melanin that is present. And this is what gives a variety of skin color varying from pale yellow, red, tan, or black. So the number of melanocytes is the same in everybody of all different shades of color. The differences of skin color is due to the amount of pigment produced by the melanocytes. So people who are a little darker skinned will have more melanocytes versus people that are a little more fair will have less melanocytes. So as we discussed in the past, melanocytes synthesize melanin or give us a tan when we're exposed to UV radiation or light. Sometimes, if we're out for long periods of time without sunscreen, we could actually damage, even though we produce some melanin, but sometimes that's not enough. We begin to damage the DNA in those intraepidermal macrophages, making us more sensitive to skin cancer. So tanning is a protective mechanism of producing more melanocytes to protect our intraepidermal macrophages, but often is not enough. Usually it's not enough. That's why it's important to use sunscreen if we go out. So we talked about how the melanocytes are located in that stratum bacilli, and they produce melanin. So the melanocytes will be stimulated to produce melanin when we're exposed to UV radiation. The difference in skin color is the amount of melanin in our skin. We all have the same amount of melanocytes, but darker skinned people will produce more melanin, number one, and darker skinned people, the melanin will extend further up those layers. So possibly a lighter skinned person, the melanin will only be present maybe in the stratum spinosum, where on the lower part of the stratum spinosum, where a darker skinned person, the melanin can extend all the way up. So other conditions that we've seen is albinism. So we've seen albinism in human, usually hereditary. We also see albinism in different species, and this is an inability of the body to synthesize tyrosine. So therefore, the melanin is missing from hair, eyes, and skin. And these people have very sensitivity to the sun. So they've got to wear sunglasses and they sunburn very easily. So they always have to cover appropriately and use skin screen. Vitiligo is present, and usually it's an autoimmune disorder, possibly. It attacks normal melanocytes. And it's like a patchy loss of like white spots. You can see it on the hands and on the face. Carotene is an orange pigment. Often you could see this in areas like, for example, the palms of our hands. And this is very prevalent in those who are eating too many carrots or vegetables in that respect. And therefore, the keratin becomes deposited in adipose tissue. There's a necessity for vitamin A, but excessive amounts gets deposited in our adipose tissue and gives those patients, you see this a little bit in maybe really strict vegetarians, but the good thing is once you stop eating a lot of that, it gets processed and it goes away. Cyanosis, so that would be a bluish tinge, especially in the lips, in the gums, in the nail beds. And this can occur where hemoglobin is not getting enough oxygen. So we see this in possibly like excessive cold, like the beginnings of someone being frostbite, circulatory and respiratory disorders. Jaundice is another condition we see. This is where we have the buildup of a yellow pigment, bilirubin, in the blood, often caused by liver disease or any kind of obstruction to the bile ducts or excessive blood cell breakdown or hemolysis. And often these patients will have this yellowish green tinge to their skin, often seen in the sclera of the eyes. Erythema, so this is a reddening of the skin, generally an engorgement of the capillaries. Often we could see this where there's some injury, exposure to heat, any kind of an inflammatory or allergic reaction can cause this. Pallor is the opposite. Often we notice it in the skin or nail beds of our gums. Some symptoms of this could either be an anemia or shock. So let's talk about accessory structures of skin. So we've got some organs that develop, which include the hair, skin glands, and nails. So let's talk about hair. There's some functions of the hair that are necessary. It's obviously protection, reduction of heat loss. That's why we would benefit from wearing a hat in the winter, and very sensitivity to light touch. So the hair itself is made up of dead keratinized epidermal cells, and the different color also is related to the melanin in the hair. So the different regions of the hair are the shaft, what you see exiting, the root going into the epidermis, and the hair follicle is the base. So let's look at what this does. So we can see the hair shaft, and then as it enters into the epidermis, into the dermis, this is called the root. So the root anchors the hair into the skin. The base would include the hair bulb and the papilla. The papilla is where we have the blood vessels that nourish the hair and is the site for cell division and growth. I know we could cut the hair, right, and we don't feel that. But if we pull the hair, this region is the sensitivity. It can hurt. So around the hair, we have what's called sebaceous oil glands. So these are oil glands that secrete sebum. And the purpose of sebum is it nourishes the hair, prevents it from dehydrating, and also the oiliness of the hair is what prevents and decreases bacterial, prevents bacterial growth. We've got these muscles around the hair called the erector pili muscles. So under stress, these can contract and the hair will lift up. We call that goosebumps. The contraction of these erector pili muscles also assist these sebaceous oil glands from secreting their sebum to protect the hair itself. And then on the bottom, we've got the hair root plexus, which are very sensitive to touch. So obviously, if you can lightly move the hair, you could feel it, or if you pull it, you could certainly feel the pain. So we can see here the hair shaft, the hair root, the papillae. Make note of these sebaceous oil glands around the base of the hair here. Okay. And then we have the papillary muscle, which, where do we have that? Which contracts and relaxes in order to allow the sebaceous oil glands to secrete more sebum. So there's three types of exocrine glands that exist around our that are considered skin glands. So we just talked about the sebaceous oil glands, right? So they're connected to hair follicles and they secrete a sebum. Sebum is important for prevents dehydration and inhibits the growth of bacteria on the hair. We also have sudoriferous sweat glands. And there's two types. There's the eccrine sweat glands and the apocrine sweat glands. So let's look at these in more detail. So the holocrine glands, remember we've learned in the past, are the sebaceous oil glands. So holocrine glands is the method of secretion. So remember we learned in the past that the holocrine secretion, the mature cell actually dies and that becomes the secretory product. In this case, it's the sebum. The purpose of the sebum on the hair is prevents dehydration and also lubricates it, kind of warding off bacteria. Some sudoriferous glands, there's two. There's the apocrine sweat glands and the merocrine sweat glands. So the merocrine sweat glands are a form of the secretory product which is sweat, is in the form of exocytosis. So these merocrine glands are considered eccrine glands, which we've discussed in the past. They're the most numerous. So they're the sweat glands that exist on the top of the skin. Their purpose is secreting sweat, often when we're overheated. The sweat has electrolytes, some sodium, some organic wastes, and they secrete this in order to cool us off. So this is a merocrine form of eccrine secretion where it's through exocytosis. And of course, it's functioning to cool us off. The apocrine glands, this method of secretion, which we've discussed in the past, is part of the cell actually pinches off, not the entire cell, but part of it. We talked about in the past that also mammary glands are apocrine glands, but the apocrine sweat glands are located, for example, in the groin and armpits, around the nipples. They're actually connected to the hair itself, and this secretes kind of a thicker sweat, not like more fluidy like the eccrine glands. And this sweat is what we call the body odor. So the sweat itself isn't, the smell isn't noxious, but if you leave it there, for example, 2 days without showering, that's where the bacteria comes and begins to eat this secretion, and it becomes what we call body odor. So the apocrine sweat glands are actually in that around the hair follicles, and they're apocrine secretion. So part of the cell becomes the secretion, and this is what gives us body odor. Where the eccrine sweat glands, as you can see here, it's just a sweat pore. Okay, so when you look at a model, if it's not connected to the hair, they're the eccrine sweat glands or the regular sweat glands. They've got the secretory vessel, provides sweat, where the apocrine glands are connected to the hair itself, and this hair is either in the genitalia or in the armpits. Ceruminous glands produce a yellow wax called sebum, and this has got a protective mechanism. It's this material traps anything to go into the ear canal. It traps dust or any particles we don't want into that area. So again, this is kind of a overview of the difference between the eccrine sweat glands and the apocrine sweat glands. So eccrine are the most common. They're all over the body. They're mainly in the deeper dermis, and their surface where they secrete through an excretory duct is the epidermis. What's secreted? It's kind of a fluidy material, mainly to regulate our body temperature, and this is active very soon after birth. Apocrine sweat glands are located in areas of the genitalia, the armpits. They're connected to a hair follicle. The fluid that's secreted is more thicker. Lots of lipids, proteins are secreted in this manner, often stimulated by emotional stress, sexual excitement, and this becomes active at puberty. So let's talk about nails. So the nails are also an accessory structure. When we look at the nail, we could see the nail body, the free edge, the cuticle in this region, and the nail bed and the nail root. The free edge is not sensitive, so we can cut our nails without any pain. But if we lift this up, this region where the nail bed is protecting is very sensitive. So what are the functions of the nails? It allows us to grasp things, to manipulate objects. It's going to protect this very sensitive nail bed. And with the nail itself, the free edge is there's no sensitivity there. All right, so let's move on to some clinical connections related to skin cancer. So when we're talking about skin cancer, what makes us more susceptible would be, of course, older in age, exposure to UV rays without sunscreen, patients that are immunocompromised, which is also correlates with increase in age, or a history, a family history or personal history of skin cancer. There's three types. There's basal cell carcinoma, squamous cell carcinoma, and the malignant melanoma. So let's go through all of this. So if you're going to have skin cancer, basal carcinoma is the best one to have. It's the most common one. It's located in the stratum bacilli, or that lower layer, rarely metastasizes, which is very positive, and it's the least malignant, located in that bacilli layer. The next one is squamous cell carcinoma. Most of these are located in the stratum spinosum. This can metastasize, um, often arises from the keratinocytes in that stratum spinosum, which is that second layer up. This one you could see often on a person's scalp, ears, sometimes the lower lip. Sometimes, if you leave it alone, it can metastasize. What does metastasize mean? Is that it spreads to other parts of our body. The malignant melanoma is very uncommon. Only 2% of this is, or skin cancer is the malignant melanoma. Their origin is from the melanocytes. So this has increased with possible depletion of the ozone layer. And this one easily metastasizes and must be treated immediately. The cancer of the melanocytes, it's the most dangerous type of skin cancer. So let's look at this. This is a normal mole that we've seen. Basal carcinoma, remember this is the best one to have. You could see probably an increased size of the mole, irregular pattern, different colors. Squamous cell carcinoma, this is the second best to have, and this is a malignant melanoma, which is the most dangerous one to have. So a normal mole and a malignant mole, often dermatologists give free skin, um, they kind of scope the skin and make sure, or look at it, well, make sure it's nothing to worry about. So when we're talking about the malignant melanoma, we talk about the rule of ABCD rule. So how can we determine if it is a malignant melanoma? A is for asymmetry, meaning the mole is not similar on one side. Maybe it's going to be, the right side looks different than the left. B is border. It's going to exhibit irregular borders. C is color. The color of a malignant melanoma can vary. Sometimes it's black, brown, tan, red, or blue. And anything greater than 6 millimeters should be evaluated by a dermatologist, which is kind of a little bigger than the size of a pencil eraser. So let's look at this in more detail. So the first one is asymmetry. Melanomas are going to appear irregular in shape. This is a malignant melanoma. B is border. So you can see how the border is irregular on a malignant melanoma. C is color. This is an extreme version, but often can be tan, brown, black, red. Of course, if you see this, get immediate medical attention. D is diameter, meaning anything larger than 6 millimeters, or the like a pencil eraser, to definitely get that checked out. So let's talk about burns and grafts. So we categorize burns in degrees. So a first degree burn is a superficial burn. So this only goes through the epidermis, or that outer layer. So an example of this would be a sunburn. We've all had sunburns, right? It's going to hurt to touch, and usually it will clear up in a short period of time, and it clears up without scarring. There's some mild pain, there's some redness or erythema, but no blisters, okay? So the skin functions remain the same. The second one is called second degree burn. So this type of burn is going to go through the epidermis, and a little bit of the dermis is injured. And this one does have blisters. So in this one, it goes through the epidermis and goes through the dermis. So when you see a blister, you're going to call it a second degree burn. This will heal. It's just going to take a little longer. Third degree burns are also considered full thickness burns. So this goes through the epidermis, dermis, and it goes into the hypodermis. And in this case, it's extreme. It's actually gone all through the skin. So obviously this is going to be very, very painful. It's going to destroy all the layers, and most function is lost in these cases. So again, first degree burn would be the epidermis. There are no blisters in this, okay? Second degree burn will go through the epidermis and the dermis, and in this one you will see blisters. And then third degree burn includes full thickness burn, and it goes through the epidermis, the dermis, and the subcutaneous layer. So in order to communicate with other specialists regarding the seriousness of a burn, we talk about the rule of nines. So when we have a full thickness burn, obviously our concern is bacterial infection. There's reduction of circulation in that area, sometimes in conjunction with decreased urine function and a diminished immune response. So these burns have to be attended to immediately. So when we're talking about the rule of nines, we divided the body up in regions of what we call nines. So the first one is let me show you an image of this. So when we're talking about the rule of nines, we consider the head. The anterior head is 4.5, the posterior is 4.5, the whole head is 9. So this is estimating the burn damage. The trunk is anterior 8, posterior is 18, whole trunk 36. The extremities are 9 and 9. Anterior lower limb is 9 and the posterior is 9. So this is how we determine the extent of the burns. So I'd recommend you go through this, kind of draw a little figure, and get an estimate of the rule of nines. The blood supply to the integument system, it receives branches from arteries, from skeletal muscles, and arteries from the skin directly. Within the skin, we've got the cutaneous plexus and the papillary plexus. And venous drainage also occurs through the blood dermis and larger subcutaneous veins. As we age, the skin's immune response diminishes. We've got more wrinkles, the elasticity and the tensile strength decreases. We've got decreased sweat production, decrease the number of functional melanocytes, that's where we get gray hair, and increased susceptibility to conditions like skin cancers. And also the growth of hair and nails decreases in age. Okay, so we've finished this section. I'll see you next time.